is Dr. Patrick Hu, CEO of Moffitt Cancer Center and SITC President, and we're here in Boston, Massachusetts at the 37th Annual SITC meeting, here with Dr. Ahmad Tarhini. Thanks so much for joining me today.
Thank you, Patrick.
Yeah, Dr. Tarhini, can you tell us about neoadjuvant therapy and IO agents?
Yes, thank you for the question. We recently published a position paper in JITC on local regionally advanced solid tumors and the role of neoadjuvant immunotherapy. Obviously, these are tumors that present a challenge in management, and neoadjuvant systemic therapy has the potential to improve the outcomes of these patients. Tremendous progress has been made with neoadjuvant immunotherapy, particularly in this era of expanding immunotherapeutic agents, supported by high pathologic immune responses that we see and the durability of these responses. In our area, melanoma, complete pathologic responses have been observed in about 20% with PD-1 blockade alone, and about 50% with PD-1 CTLA-4 and PD-1 LAG-3 inhibitor combinations. Importantly, for the first time in melanoma, the SWOG S1801 study has now reported a significant improvement in event-free survival in a randomized study with neoadjuvant pembrolizumab compared to the standard surgery plus adjuvant therapy approach. Importantly, neoadjuvant studies allow the assessment of radiologic and pathologic responses, as well as the access to biospecimens before and during treatment. Pathologic responses can guide future treatment decision making, and biospecimens allow the conduct of mechanistic and biomarker studies that can guide future immunotherapeutic drug development. So it is an emerging, rapidly growing area that we're very excited about.
So it's possible if you give the immunotherapy while the tumor is in place, that can stimulate the immune system even more because the antigen is there that will stimulate the T cells?
Absolutely, and there is evidence to support this in terms of expanding immune profile in the circulation and within the tumor microenvironment, including immune memory cells.
You also had an exciting presentation today. Can you tell us about that?
Sure. We had a neoadjuvant study which tested an immunotherapeutic approach that combined plasmid IL-12 electro gene transfer combined with PD-1 blockade in local regionally advanced melanoma. Obviously, the plasmid is injected into the tumor, and with electroporation allows transient permeability of the cellular membranes to allow the uptake or transfection of the plasmid into the cells. This leads to the expression and release of IL-12 within the tumor microenvironment, leading to interferon gamma secretion from T cells, dendritic cells, and NK cells. Now, this leads eventually to an IL-12 interferon gamma feed-forward loop, and evidence of increased effector cell activation and even evidence of memory cell generation. The study was promising in its preliminary stage at this point. We had complete pathologic responses of about 67% and major pathologic responses of about 89%.
Wow.
We interrogated the tumor microenvironment. We looked at CD8 T cell infiltration, PD-L1 expression, and interferon gamma tumor inflammatory signature. And interestingly, in 4 patients who were predicted to be non-responders based on these profiles, all 4 achieved a complete pathologic response, which provides additional support to the testing of this combination at this early stage. We looked at the periphery, and so we saw evidence of short-lived effector cells to be significantly reduced at 4 weeks, but then they were kind of upregulated up to baseline levels before surgery. In parallel, memory precursor effector cells were actually upregulated, and there was a significant increase in proliferating CD8 positive, PD-1 positive T cells at 4 weeks, and then that was maintained on later time points. We were interested in looking at the cytokine profile in the serum in the periphery, and so we saw no biologically meaningful changes in interferon gamma levels, IL-2 levels, and IL-12 levels, which was consistent with the favorable safety profile that we saw during the study. Finally, basically, the study passed its efficacy criteria for the stage 1 testing within the 2-stage assignment design, and now we're enrolling into the stage 2 of the study.
Tarhini here from the Cutaneous Oncology Group at Moffitt Cancer Center. Thanks for being with us today.